Hello, I'm a geriatrician, and for the last 25 years, each morning I've been seeing patients presenting with a new surgical emergency and need for surgery, and people who've just returned from surgery, having had surgery for an orthopedic injury. What I want to share with you is not a geriatrician's perspective on geriatric medicine and the management of the frailty and the complex medical comorbidities those patients have, but to just distill out some of the priorities that everybody else, the whole team, needs to have. I do, the surgeons do, the anaesthetists do, the nurses do, the emergency department's team need to, etc. What do we all need to try and do for this typical lady? This is a made-up case, but it typifies the sort of person we'd be talking about. An 82-year-old lady with a background of some medical problems, some prior cognitive difficulties, who's now in hospital with a hip fracture. And unlike some other specialties, the hip fracture diagnosis is known from the start. There's not a lot of chasing around trying to investigate necessary. We know what's there, and the surgeons will have a very clear plan as to what they would like to do about it if all else were to permit it. They want to do an operation, and we would all agree, and I'm sure she would agree, that it's a matter of urgency. If you wind the clock back a couple of decades, it wasn't an emergency, and it took quite a lot of research over the years to try and create a sense that the urgency of hip fracture surgery mattered. Huge observational studies like this showing that the delay in operation varying around the country for individuals, with delay in surgery translating into an increased risk of mortality or poor outcome for individual patients, was hampered by the fact that these results, even if they've been adjusted for comorbidities, really haven't been adjusted for comorbidities. The patients who get delayed tend to be more complicated. They may not have the big comorbidities that might be adjusted for in a trial, but they have things wrong with them that make it more difficult to get them to theatre. And the things that make it difficult for them to go to theatre also make it difficult for them to recover afterwards. And it's difficult to prove that the delay to surgery is actually a consequence of, is actually the cause of poorer outcome. When we were writing the NICE guidance back in 2011, we could look at the very thin evidence base on early versus late surgery from proper randomized controlled trials, and it's difficult to see a powerful effect there. Which didn't stop us writing a guideline which argued that these patients should all be offered multidisciplinary assessment to rapidly optimize them for theatre, that surgery, it was only compassionate to get on and operate on people on the day they came in or perhaps the day after admission. Nobody should have to lie in hospital in bed with a hip fracture for 2 nights in a row simply because we weren't organised to provide surgery for somebody who we know is coming, because every hospital has a couple of patients admitted with this injury each day. If we're going to do that, we need to think about how we develop pre-operative protocols, so the things that might get in the way of that process are dealt with rapidly. Anaesthetic fitness has been a subject for great debate over the years. Anaesthesia is a hugely complicated subject, and even after all this time getting people ready for theatre in liaison with anaesthetists, I find it very difficult to find my way through the complexity of the anaesthetic options available to them and the pros and cons of each. But luckily we don't really need to know about that. Anaesthetists get on and do the right anaesthetic for their patient. There is huge variation between different hospitals around the country and the cocktail of anaesthesia that was being offered by different anaesthetists. This is work from our anaesthetic sprint audit back in 2013, showing that huge variation. That audit led into the anaesthesia publication in 2020, a guideline for the management of hip fracture, a real consensus of anaesthetists pulling together the attitudes and approaches to this frail group of patients and making some very clear recommendations that build on pre-existing guidelines. but making it clear that you really had to have something very wrong with you for it not to be appropriate to get on and have an operation for hip fracture. So there's an urgency about doing it, and there's definitely a mandate to operate on patients. Now, when I started, 5 or 10% of patients didn't get surgery. That figure's dwindled, and across the country is now about 2% of patients don't have surgery if they have a hip fracture. 1% of those patients, for 1% of those patients, the fracture's actually impacted or partially healed, so that surgery was no longer necessary. And in another percent, or thereabouts, the patient was getting ready for theatre but died of something else while they were being got ready for theatre. There are very, very few patients being diverted into non-operative management now. And attitudes around the country, on the best days, the attitudes of orthogeriatricians, of surgeons and anaesthetists run a little bit like this. My job is to see if there's anything I can do to try and make this lady fitter. The surgeon wants to know why she isn't getting to theatre straight away. Why isn't she listed first on the list rather than that person who's needing their wrist fixing, who could definitely wait? And the anaesthetist has generally got the attitude that this person is going to go on to today's list. So long as they can lie flat, it's pretty difficult to give an anaesthetic to somebody who's so short of breath that they can't lie flat. But those are the sort of gung-ho attitudes that are now prevalent in the UK. And that's led to a diminution of numbers of patients being managed conservatively, essentially getting end-of-life care rather than an operative attempt to make them more comfortable. And that's led to a halving of mortality in the UK over the course of the last 15 years. But these are really complicated patients. I've talked elsewhere about the frailty index, but if you look at patients presenting with hip fracture and ask them a standard set of questions about their function, their medical and psychological health, what you find is that many of those patients have huge numbers of other problems that might lead to distraction and confusion and concern when people are getting them ready for theatre. Some of those problems are practical. Many of them, though, are medical comorbidities that may or may not have implications for surgical and anaesthetic approach. And many of them are psychological, which have serious challenges, can pose serious challenges in the perioperative period. So these are complex patients, and I'm not going to take you through how you manage all of that. That's called comprehensive geriatric assessment. That's an undertaking that it would take hours for me to explain the complexity of how we play with all of those, juggle those 15 balls of complexity for each patient, and deal with the fact that the management of one of those conditions will be deleterious to another, that the treatment we might use for one condition could lead to a worsening of another. That's comprehensive geriatric assessment and geriatric medical care, and is another topic. And I think it's important that when you're thinking of somebody coming in to hospital having suffered a hip fracture, they've suddenly dropped into a state of dependency, they can't get out of bed. Don't be distracted by the complexity of their possible rehabilitation in the future, how long they might be in hospital. Don't be dispirited by that. That sense of pessimism that was there back at the turn of the millennium shouldn't be there now. Don't worry about that. That's something that will follow. What needs to be the concern when people first present to hospital is, can we avoid this person falling so far down this functional abilities? Can we reduce the depth of the insult, the damage that's been done to them, the physiological stress that they're under, so that they have less of a battle to climb back from? So don't be distracted by the patient's apparent prognosis or the possibility that they're going to be in hospital for a number of weeks. Just focus on minimising how long they wait for surgery and how physiologically damaged they are by the acute surgical fracture and anaesthetic insult. And if we're going to try and do that, we have to think about what the immediate consequences are of breaking your hip. Unlike general surgery, where pus, bugs, blood, everything swilling around in the abdomen. The patient can be under an enormous physiological stress with sepsis and so on. Hip fractures are a nice, simple condition, and relatively little happens to this lady when she falls over and breaks her hip. In fact, I think there are only really 3 immediate physiological consequences of a broken hip that we should be thinking about, and that's a manageable number of things for the surgical and the peri-operative team to be thinking about for her. The first is she's fallen. That means she's tired, frightened. She may have spent a long time on the floor. Her view of the world has suddenly changed. She's lying flat on her back in hospital, in bed, looking at the ceiling. She's not able to engage with what's going on around her. So immobility can be a real challenge for her. If she tries to sit up, she can start to catch up with the world. Being propped up with a broken hip, she can start to see what's going on. But it's not until she's had her hip fixed and is sitting out in a chair that she can really start to engage with what makes life worth living. Start to eat and start to understand what's happening around her and make progress with her rehabilitation. So immobility as a consequence of a hip fracture is a huge challenge. It's frightening. It displaces somebody from coping to not coping. And for people with dementia, that can be an enormous insult. If you've been ticking along in a normal routine, functioning on autopilot through many of your days in your home or in a care home, and you suddenly have something like this happens to you, you lose all of your points of reference and you will become bewildered, confused, and delirium is a topic for another talk. Immobilization also carries other concerns. So there's obviously going to be a risk that people develop a pressure sore if you're lying on a hospital trolley, unable to shift yourself around, take the weight off your pressure areas, unable to move yourself at all. Your pressure area is at risk. So we need to consider that sort of question as well. And immobility will also increase the risk of deep vein thrombosis. So these patients have an injury at the hip. There will be blood. There will be blood clots forming in some of the small vessels around the fracture site itself, and there's a real risk of these patients developing deep vein thrombosis. It's not as big a risk as you might think. These patients have a very, very high relative risk of developing a deep vein thrombosis compared to you and I, unsurprisingly. But their absolute risk of developing a deep vein thrombosis after hip fractures is surprisingly small. We did work on this using all of the patients over many years in our hospital and looking to see what proportion of them developed a deep vein thrombosis during their time in hospital. And the answer is it's about 1.6% of patients will develop a deep vein thrombosis following hip fracture. Or it was until we started using low molecular weight heparin several years ago in compliance with NICE guidance. And that halved the risk of these patients having hip fracture, developing a deep vein thrombosis. So the actual rate of deep vein thrombosis in our hospital now is less than 1%. It's 0.8% over recent years. So a complication, but not a terribly common complication. Immobilization may sound straightforward. Immobility may sound straightforward to cope with, but patients need to be able to move even if they're staying in bed. They need to be able to get on and off a bedpan, and rolling to get on and off a bedpan is a ghastly experience if you have a broken hip. The pain of a broken hip is not the pain of an arthritic hip. It's not the pain of a tumour. It's not the pain of a coronary. It's incident pain. It relates to movement. When these manoeuvres, moving around in bed, moving on and off a trolley to go from one department to another, moving to have an x-ray, when those movements happen, the patient will be in excruciating pain. So we need to find a way of dealing with pain that can cope with movement, not just keeping people comfortable resting in bed, if we're to avoid them being stuck, unable to move, and at risk of developing pressure sores. So within our department, and this document is widely available in formats that you can cut and paste into your own local protocols. Our approach within my hospital has been to develop a standardized assessment protocol, but to have a bundle of care that is the back page of that takes us through how we would manage these patients, the sort of care that we would provide to them to get them through these aspects of the immediate aftermath of a hip fracture, the immobilization and the pain that are the first two consequences of having a broken hip. So making sure that everybody gets pressure care, that people aren't left on trolleys without a pressure relieving mattress, that everybody gets regular paracetamol analgesia, that opiates are available, strong opiates, and we use oral morphine as a routine, are available to patients in the pre and the post-operative period in a very flexible fashion, with nurses able to give people strong analgesia at an early stage, not using codeine with its constipating risks, just getting on and using appropriate and adjustable doses of morphine. But if I go to the dentist to have my tooth drilled, I don't ask him for morphine. I ask him for a nerve block. And if the same is true, if I have a broken hip, I don't want somebody to give me enough morphine to make me constipated and confused. I want them to give me a nerve block. And the fascia iliaca block is a very simple procedure. It's a straightforward, very safe undertaking, can be done by people without a lot of training, doesn't need radiological guidance, and is something that should be available. And the National Clinical Audit, the National Hip Fracture Database, has shown that rates of nerve blocks are improving enormously, and that's going to be the focus of one of the performance indicators that the National Clinical Audit uses in the future. Putting a catheter in, it feels a kind thing to do to people to put a catheter in, though I'm not sure I'd want to be. I'm not sure that most ladies would want to be getting themselves into the right position to have a catheter put in if they had the choice about it. It makes nurses' life easier, but having a catheter leads to a number of risks. Risk of infection. The bladder will spend time empty. Patients lose an understanding of what might previously have been quite complicated continence control. And the risk that catheters are left in so that patients don't have to be helped, given the analgesia and the support to get up and start moving and get back to using a toilet at an early stage, can be deleterious to recovery. Everybody is going to get constipated. If you're in bed, dry, in pain with strong painkillers, you're unlikely to have your bowels open. So making sure aperients, laxatives are available, along with antiemetics to counteract the effect of strong painkillers. Making sure everybody's given fluid, and we'll talk in a moment about why people are needing fluid, but everybody is going to need fluid in the time before surgery. Alcohol withdrawal is a common concern for the group of patients who fall over, particularly in younger men presenting with hip fracture. So being aware of that and preempting it with withdrawal regimes and vitamins is important. Antibiotic prophylaxis, well, the appropriate antibiotics are often determined by individual hospitals, but something will need to be given for the peri-operative period, and we use a single doses of antibiotics in theatre for that. Medication review. There are some drugs that you don't really want to find on the drug chart when patients are going to theatre. In particular, ACE inhibitors and ARBs have the potential to make patients drop their blood pressure to a greater extent in the perioperative period, and it's worth missing those out to try and avoid hypotension and acute kidney injury. We start loading all of our patients with vitamin D from the moment they're admitted. We don't check their vitamin D levels. We assume patients are likely to be deficient or relatively deficient. We load everybody with vitamin D in anticipation of a post-operative discussion of bone protection management. Patients need to be kept nil by mouth, but they don't need to be kept nil by mouth overnight in case surgery is first thing tomorrow morning. You need to be starved for 6 hours and kept on free of any clear fluids only for 2 hours. So we encourage patients to have a high energy, clear drink 2 hours before surgery so that they're not feeling deprived and hungry when they go to theatre. skin marking and consent is on there as well. The third consequence after immobility, pain, is bleeding. And somewhat astonishingly, the blood loss associated with hip fracture is rather larger than the average blood loss of somebody presenting to the medical take with a query GI bleed. The blood loss for some types of fracture, the multi-part unstable trochanteric fractures, the subtrochanteric fractures, runs to 3 or 4 units. And the patients, that sort of group of patients who are having DHSs and nails, we would expect to see that sort of scale of blood loss. So if people present with hemoglobin, a normal hemoglobin of 11 or 12, they're going to drop it to 7, 8, 9 in the post-op period. We can anticipate, we know that's going to happen. So anticipating blood loss is something that's really important. And the second part of our care bundle is dominated by the hematology for the patient. So making sure that everybody has blood made of sent for group and save, so that it's possible to cross-match people in a hurry if necessary. If we're needing to transfuse people pre-operatively because their hemoglobin's down below 100, then checking B12 and folate and ferritin seems a sensible thing to do, so that one can try and establish why they've become anemic in the first instance. High risk operations, so the unstable fracture types, pathological fracture types, and people with coagulopathy or liver failure, we would always make 4 units of blood available before the patient goes to theatre. And coagulation issues are a real concern. Aspirin and clopidogrel used to be a concern for us, and a number of projects over the years have shown that's not necessary. Now patients should get on and have surgery if they're on aspirin or clopidogrel. It's not really necessary to stop them, though in my practice we tend to omit the clopidogrel in the post-op period until we've seen that there's no wound bleeding. So we don't give it on the morning after surgery until we're comfortable that there's no wound bleeding. But prolonged omission of these drugs is not necessary. The only real concern that we have now on the back of the anaesthesia guidance is that if people are on both aspirin and clopidogrel, then that dual antiplatelet therapy can lead to major difficulties, and certainly giving a spinal in that situation is a challenge and a concern. Though it would be, anybody who's on both aspirin and clopidogrel needs their history taken to establish quite why they were. But aspirin, clopidogrel, largely not a concern anymore. Warfarin, the approach that we take is that so long as the INR is below 1.5, we can get on with operation. We give 5 milligrams of vitamin K to patients whose INR is high, or frankly, one should be giving 5 milligrams of vitamin K to people presenting with a hip fracture who are known to be on warfarin, because it's very likely their INR is going to be high. And the sooner you get the vitamin K in, the quicker it's going to work. Vitamin K will halve your INR in the course of 6 hours on average, but it's a very widely distributed average. But the sooner it goes in, the better your opportunity to get people to theatre by the next day. The direct-acting oral anticoagulants, the DOACs, the NOACs as they were called, are more challenging and because they're relatively recent. It's only now that we're getting a consensus as to how to approach those drugs. But in general, if your patient is able to excrete a Pixaban or a Rivaroxaban or a Doxaban, we would be able to get on and do surgery after about 24 hours. But many patients aren't able to excrete these drugs. Renal function is important. Many patients have much worse renal function than you would anticipate. Don't look at people's creatinine. Don't look at their EGFR. Those are not investigations that are remotely relevant in this situation. You need to think about people's creatinine clearance and calculate their creatinine clearance. The little old lady with a broken hip, her weight and her age mean that EGFR estimates are very falsely reassuring about patients' renal function, and most patients will be 1 stage CKD worse than their EGFR might suggest. So to look at their creatinine clearance, and patients with a prolonged a prolonged creatinine clearance. Patients with abnormal clotting on the 10A inhibitors may need longer to wait for surgery before you could be confident that their clotting is okay. As is also true for dabigatran, though that's very rarely used in my practice. Tranexamic acid seems to be being given by everybody. The direct studies of that in hip fracture are not there, but the benefits are apparent, and it doesn't seem to be associated with a concern over deep vein thrombosis risk. And as I've said, everybody is at risk of deep vein thrombosis. The risk is not huge, but everybody in our unit goes on to enoxaparin unless there's a specific indication. So the thromboprophylaxis assessment in our care bundle summarises the very few reasons why I wouldn't want somebody to have enoxaparin before going to surgery for hip fracture. When people go to surgery, the physiology gets a little bit more complicated. So we've had immobility, we've had pain, and we've had bleeding. In theatre, there's an additional issue of hypotension, part of that reflecting operative bleeding, though the amount of blood that's seen in theatre is very much less than the amount of blood that the patient's lost pre-operatively and post-operatively. But anaesthetic agents are all vasodilators. Patients will drop their blood pressure in response to general or spinal anaesthesia. And in this is again the anaesthetic sprint audit of all the UK practice back in 2013. You can see that many patients, the majority of patients, 3/4 of patients, developed absolute hypotension at some stage during their operative management. The skill of the anaesthetist in managing hypotension is extraordinary. That's what they do. They're not only managing hypotension, but they're also translating that into tissue perfusion, and their role is to ensure that the brain, the kidneys, the vital organs remain perfused, and manipulating blood pressure through the use of fluids, bloods, and vasoconstrictors is what they do in theatre. What I've found in a number of places is that they're not very good at communicating the complexity of that to the poor suckers on the ward who receive the patient when they come back from theatre. So this patient's had an hour with a one-to-one relationship with a consultant anaesthetist who has a very good sense of what this person's optimum blood pressure is, how much fluid they've lost, how dry they are, how much vasoconstriction was necessary, how much of that was down to the anaesthetic. But then they return to the ward without a clear guidance for the ward team to know how to manage hypotension if it were to arise during the course of the following evening or the next day. So we've developed a post-operative care bundle which requires the anaesthetists just to summarise their thinking about the patient's fluid management, how much fluid they think the patient's likely to need overnight, and what target sort of blood pressure patients should be managed towards. All patients with hip fracture are different. Some people are functioning with a very low blood pressure on a good day. The anaesthetist's sense of what would be a safe blood pressure will be very individualised, and just getting that written down is hugely important. We also ask the anaesthetist to have a think about the preoperative haemoglobin, the blood loss in theatre, to check a haemoglobin using a blood gas machine or whatever equipment in recovery, so that there is a record of what this patient's haemoglobin was before they left the recovery suite. And we don't ask for transfusion at a particular threshold, but we ask the anaesthetist to think whether, if this patient needs a haemoglobin of more than 90 tomorrow morning, and I want them to have a haemoglobin of more than 90 tomorrow morning, how much blood might they need to receive overnight to achieve that? I'll come back to the issue of blood transfusion in a little. The care bundle then specifies what the orthopaedic juniors on the ward might need to be thinking about during the course of the morning, and gives a care bundle for the next morning where there's the expectation that we should examine patients to see what their pain is, to look at what analgesia people have had, what opiates they've had, then to move the leg gently to see whether there's enough analgesia on board for the patient to be able to sit up, to sit on the side of the bed, and to stand up, which are the objectives of the physiotherapist on the first day. If they're not had enough analgesia to do that, then the expectation is that the opiate dose will be adjusted. And that's a daily process on the ward of adjusting patients' opiate management, discussing it with them, looking at how well pain on movement is controlled so that people can get up. The expectation of the juniors is that they also respond to the anaesthetic guidance on fluids and blood to make sure that patients have enough blood pressure to be able to get up, and a haemoglobin that doesn't leave them too exhausted to progress in physiotherapy. We encourage people to write up nutritional supplementation, in part to make sure it's on the drug chart, and in part to educate junior doctors on the importance of nutrition. Another talk I've done. We try and get catheters out at the earliest possible opportunity. And then we screen everybody with a 4AT score. The 4AT is a brilliant tool designed to identify delirium, both to identify, recognise and stimulate the treatment of delirium, and to teach junior doctors the importance of delirium management. The topic of another talk, but delirium is the commonest complication of hip fracture surgery. Bleeding after hip fracture surgery will be 1 or 2%. Infection will be 1 or 2%. Deep vein thrombosis might be 1 or 2%. Rates of delirium are 25 to 50% after this. People who develop delirium after surgery are 4 times as likely to end up living in an institutional care and twice as likely to die. Delirium is a staggeringly important function. And by screening for delirium in the post-op period and having 4AT scores available on everybody who's had hip fracture in the UK, we're starting to show that the 4AT, the ability to prevent patients getting delirious in the post-op period, is the best way of gauging the quality of the anaesthetic and surgical care they've had in the peri-operative period. If you do post-surgical care, surgical care, anaesthetic care well, people don't end up delirious. They get home quicker. If you do it well, patients can get out of bed on day 1 post-op. They make rapid progress. So measuring those as an outcome of the quality, as a measure of the quality of peri-operative care, is really something to examine. I talked earlier about transfusion. Most of the trials that have been published in the literature have been fairly simplistic in that a threshold for transfusion, post-operative transfusion, has been set, and studies have then examined whether people who were transfused above or below that threshold did better or worse. The problem with that is that the post-operative haemoglobin checked on patients will be checked the day after surgery. The result will eventually come back and a transfusion will eventually be given, potentially 24, 36 hours after surgery. That's just too late to influence their outcome. If we're trying to prevent people being too confused or too hypotensive and underfilled to be able to get up day 1, there's no point transfusing them day 2. So I think those trials have been poorly designed. There are some suggestions in this lovely paper that in patients who are the most exhausted of our patients, that the very frailest of our patients, there's a real advantage in aggressive transfusion so that they're given the best opportunity. But all of these trials struggle. And that takes you back to my recommendation, is that you shouldn't be setting a transfusion threshold for post-operative blood. You should be setting a transfusion target for the morning after theatre. And transfusion is therefore the responsibility of the surgical team and the anaesthetic team on the day of and the evening after surgery to make sure that patients are transfused in anticipation to prevent them developing delirium, hypotension, and failing to progress. And those remain the targets. They're this patient's target. She wants to be out of bed as soon as possible. She's not interested in how soon she has surgery. She's interested in how soon she has surgery that's so good that she can get up and she isn't confused after it. And those are the objectives. And I think if we can improve the quality of management of those aspects of surgical care, the preoperative immobility, preoperative pain, preoperative blood management, and post-operative management of blood pressure and fluids, that is the best way to minimise the stress on this lady. Her frailties will all be there. The 15 things that are wrong with her, that when she came into hospital, will all still be wrong with her when she comes back from theatre. But if all of those ghastly problems have not been assaulted by an unnecessarily powerful insult of drops in blood pressure and distress in the perioperative period, she's much more likely to bounce back and progress than she is if we don't get surgical care right. Thanks.